The overall topic is the ethics of perinatal care, mobilizing a new obstetric quality and patient safety paradigm. Um, Disclosure, as of now, I am employed by UW in the School of Medicine Beginning Department. In a particular role, this role does not relate to the work that I'm presenting to you today, so I do have approval to do that, but that's my only disclosure. Again, this is a two-part series to enhance clinicians' practical knowledge, skills, and mindset so that they can embody a community-focused critical consciousness during the provision, training, and evaluation of hospital-based obstetric and perinatal care. This approach affirms, activates, and amplifies the power and potential of Black women and people rather than framing Black reproducing bodies or Black births as pathological across perinatal clinical ethics and theories of change. So session one, as you heard, is called Positive Birth Outcomes and Harmful Experiences. Again, this description of this particular, the next kind of 30 to 40 minutes, we will explore the contrast between the institutional definitions of safety and the lived experiences of safety as defined for, by, and with Black mothers. Participants will examine how systemic structures define being safe and how these definitions may not align with feeling safe experiences of patients. This session emphasizes the importance of community wisdom and shaping perceptions of quality and safety. And as you heard, the learning objectives for today, I hope that at the end you'll be able to better evaluate Black birth outcomes using health equity definitions and Black mothers' lived experience, that you'll be able to define the limitations in the existing obstetric quality and patient safety paradigm in the United States, that you'll be able to explain the difference between being safe versus feeling safe, and then you'll be able to analyze a Black birth narrative, because we will practice today, within the context of emotional safety and emotional harm. A little bit more about myself. I do identify as a Midwesternized Southern Black woman from East Nashville before gentrification. I am very grateful for the gift of the liberal arts education from fifth grade actually to the completion of medical school. I am a lifelong learner. This is the way. I also identify by all these things that are bolded for you as a proud Black feminist, a reproductive justice avenger, a Wakanda healer, a Yoda follower, Care Bear hugger, all the things that are there, especially a health systems disruptor, transformer, and architect. I am celebrating my 23rd and a half anniversary celebration as a community-based trained and serving midwiferized dissident and recovering OBGYN. And I say midwiferized because my chair and residency program director and associate program director back in the early 2000s were both the OBGYN collaboratives for the largest midwifery group in Chicago. So I don't even understand how to do this work without being in collaboration with midwives. And my purpose is to advance cultural rigor through the operationalization of Black feminism, reproductive justice, and research justice in participatory quality improvement and implementation science, practice, and research, as well as interprofessional education and training. So if you would kindly open a second browser or gather a smart device, and I would invite you to participate even in a more kind of semi-structured way during the course of today's training and the training for next month. This information should also be in the chat. So go to menti.com and enter this code on your screen, 65929767. You will also know I've integrated my slides into Mentimeter. So at the top of every slide, you will always see this link here, as well as the code in case you get lost, get disconnected, and for people who are joining. And again, thank you all so very much. I will be able to see the number of people who are joining in the right lower quadrant here. Right now, I know that I think at about 5 after the hour, about 50 people had joined. There are 27 people who are now in Menti with me. And so as that number in the corner gets to about half, I will just move forward and this link will stay open for the next 24 hours so that you can always continue to participate. So starting off with, I think, hold on. I don't know if I actually wanted to start here. Hold on one second. I'm like, did my slides get moved around? I hope not. Yes, they did. So we're going to go forward and go backwards a little bit, but it's all good. So what is your primary role in your daily work? And these are the labels that I have placed. So I'm already kind of shaping or coercing you to choose from options that you did not get to choose from, which is what we do in survey design, right? So if your role is not listed, that is all right. Please feel free to enter that role in the chat. And then I can revise this question for next time. And as you can see with Mentimeter, I can ask you questions. You can participate anonymously. And we will have real-time data visualization of your responses. So about 35 folks have signed on to Menti.com, and we can see right now that the majority of people who are participating in Menti.com for this talk are practitioners, followed by my role is not listed. I will definitely take note of that. And then we'll see administrator, advocate, and researcher. And then bear with me, I may have to go forward then to go back. Okay, we're going to still go forward. Now, for this exercise, please think of one word only, one word that comes to mind when describing mothers and birthing people. And when you kind of have that one word, please type in that word, and that word will show up as well as the other words by participants in a word cloud so that we can automatically see the words that come to your mind, with the most frequently used word being in the center of the cloud, and other words that are still of value but may not be as frequently used will begin to center, will begin to be around the margins, right? With the largest words being in the center, and that represents the words you all are all frequently using together. So right now, the most commonly used word that comes to mind when thinking about mothers and birthing people is vulnerable, surrounded by strong and their strength. And we see courageous, warriors, grounded, sacred, cherished, magical, anticipating, beautiful, ignored, nervous. Thank you all, the first responders and everyone that followed. We're going to go forward, but again, I may have to go backwards one time to pick up the slide out of order. Okay, so let's go here. So again, using this one word kind of practice, what is the one word that comes to mind when thinking about quality of care? What one word comes to mind when thinking about quality of care? Again, thank you, first responders. So we saw patient-centered, we see patient-centered again, we see mixed, present, bias, safe, honor, improving, person-centered, presence, trust, listen, compassionate. Again, these are all coming from you all without me having met probably the majority of you all. And again, we get to see how many words are coming to mind right now, the words as things move. And I think you have 3 opportunities to participate each time. Patient-centered, right, is now kind of at the top. We see trust, we see safe, we see important, but we also see things as lacking, right? We see things as underdeveloped. So thank you all for participating in that. I'm going to keep going, but you can continue to participate. So here's another opportunity. Identify one word again that comes to mind when thinking about childbirth. And hospital says, and thank you, first responder. The first word came safe, then followed by fraught, right? We see an opposing thought here. We also see medicalized, thank you, responders. Rigid, overwhelming, scary, sterile, dangerous, expensive, stressful, uniform, complex, overwhelming. And again, thank you all for this rich tapestry of your thoughts. Perhaps also your knowledge and expertise about thinking about childbirth. Again, you can continue to participate in this. Now, now you can participate with some phrases. So in your own words, plural, you can use incomplete sentences. I forget the number of characters you have, maybe 240, but it may tell you on your smart device or your second browser. What is the meaning of patient safety to you right now in this moment? And who's going to dare to be our first responder? What is your definition? Thank you, first responder. Patient safety to you all. And as you can see, as the responses again begin to populate, they'll be presented on the screen. And as more responses show up, the screen may go up. So if I remember how to do this correctly, I'll stop the screen so we can share. But we're seeing, being seen, heard, and expertly cared for. That's a new one, those latter words that I've seen. Patient-centered care, trauma-informed staff, truly cared for. Attention to the patient's needs and well-being, paying attention, patient-centeredness, listen to, respect it, individualize quality evidence-based care. Don't have to be vigilant, can focus on healing. I hear that patient-centered responsiveness. Give me a moment as I try to move the screen up. If it doesn't work, ooh, it's working great. We see good outcomes. We see trauma-informed care, physical and emotional comfort, communication, trauma-informed. Thank you again for this rich tapestry of words and thoughts. I really appreciate that. Now, based upon what you have shared, now let's take that a little bit further. We started with meaning. Let's go to manifestation, right? How does safety show up or manifest during a hospital birth? Right? So we started with one word thoughts, then we went to kind of meanings. Now we're going to manifestations, right? We can have all these words, but if we are not collectively kind of united on how these meanings manifest, right? Then how can we monitor? How can we manage, mitigate? So for you all, manifestation means clean, sterile environment. It means advocates. It means communication, choices being offered, differentiating between choices made for pregnant person versus infant. Thank you all for responding. It means everyone gets out alive. It means attentive to mother's body, baby's heart rate, etc. Listening and responsiveness. Again, these are what you all are thinking. If you have different thoughts, please go ahead and provide them as well. Or if you want to echo what someone has said, you have the opportunity. But again, just wanting to get a sense of where this group is thinking about how safety manifests or shows up. Okay, I'm going to keep going. Now, in your own words, describe the meaning of being safe. And for some of you all, you may say, well, I just did that, right? But again, what is the meaning of being safe? And it's okay if you want to put the same thing. I'm just getting a sense of what you're thinking and then being able to share that through this platform so that we all can see this. So thank you, first responders. Being safe is listened to and medically cared for, not fearing physical harm, feeling clear-headed, feeling supported. It means unharmed. It means trusting those around me, people attentive and present, not rushed, but aware with clear communication, psychological and physical safety. It means being free from any harms and having the best medical care. It means being able to speak and be without fear of negative consequences. Thank you all for sharing. Let me see if I can move okay, this is when I don't want to do this. Let me see if I can now go back. If I don't do this correctly, I'm going to skip it. Here we go. All right, I'm going to try to move this down. There we go. Intentionally and consistently working to prevent or reduce any type of harm, low cortisol, able to breathe, make decisions freely, able to focus on personal needs. Again, thank you all for that. I think I have one more. Again, in your own words now, what is the meaning of feeling safe? There's being safe and feeling safe. And for some of you all, there may not be a distinction. But we will see today how in the systems that we kind of operate in, there are clear distinctions between the two. So again, I invite you to consider what the meaning of feeling safe is to you. Thank you, first responder. I see trust, relaxed in my environment, trust those caring for me to do what's best for me. No scary things occur. Thank you all. Knowing if there is an emergency, staff knows what to do, or no, plural, staff know what to do. Getting good medical care, not having unnecessary stress. Knowing that there are others looking out for my needs and trusting in my own ability. You see, trusting, trust, calm, ability to be and express myself without fear of judgment or negative outcomes, feeling like I'm free. So I'm getting a sense from these 13 people, 14, trust, protection from consequences, of wanting to be or to feel safe. I'm also seeing like liberation, right? And anticipation, the knowledge of what to anticipate. Thank you all so very much. And we'll end with this one. So at the beginning, I asked you to think about one word that comes to mind when thinking about mothers and birthing people. So now I would like to ask you to think about one word that comes to mind when describing Black mothers and birthing people. Again, one word that comes to mind when describing Black mothers and birthing people. Thank you, first responder. Special. Thank you so very much. What are other one words that come to mind? Vulnerable and strength, acting at the same time, right? These opposing thoughts. Vulnerable. Again, we see strength. Uh, Vulnerable, amazing, incredible, ignored, at risk. But we do see vulnerable repeated multiple times. Anxious, loving, resilient, incredible people. Anybody else wants to go? So as you're thinking about that one word, when I have done this exercise, what has happened, and I've done this with midwives, OBGYNs, clinicians, researchers, advocates, community people, normally, well, I shouldn't say normally, in my experience in doing this for the last 6 years, when I ask about the one word that describes mothers and birthing people, there's usually the first word hasn't been vulnerable. It has been powerful, very life-affirming words. And then when I get to asking about Black mothers and birthing people, well, vulnerable becomes the leading word. So in this particular group, right, on the ethics talk, is it surprising that vulnerable is the word used for both groups, considering what is the state of maternal health in our country? So thank you for that. So I'm going my best to get through this in 20 minutes. We'll see. I want to leave time for you all to ask some questions. So I like to start off in a way that situates the problem with the system and doesn't problematize or pathologize or blame Black mothers and birthing people. So I start by saying discrimination is a factor in every 1 to 3 pregnancy-related deaths in data that was shared with us by the CDC in 2020 based on 38 states who submitted their data through the Maternal Mortality Review Committees, the MMRCs, and 523 of 25 deaths. So when discrimination is contributing to over 30% of pregnancy-related deaths, and we know that those deaths are over 80% preventable, they're predictable, right? And they are disparate. How are you measuring discrimination during pregnancy-related care? And how are you starting your conversations about Black maternal health? You will never see me start off saying Black women are, you know what to fill in the rest, because by doing that, we are actually displacing the blame on the patient. When in fact, if we were to reinterpret the data in a different way, as this graph shows us on the right, this is data from, again, maternal mortality rates presented in 2022-2023 data, that for every other racialized group, the pregnancy mortality rate decreased. And so I reinterpret this as saying that white, Hispanic, and Asian mothers and birthing people are 3, 4, 5 times more likely, and I think it's even greater than that, to survive pregnancy and childbirth compared to Black women, where the rate actually went up. So if we were to rephrase even the interpretation of the data, would our approaches be different? Would our presentations be different? Again, going back to this 98% of people who are still birthing in hospitals, whether by choice, coercion, or force, 98% of births are still happening in the hospital setting. Despite the numbers increasing of community births happening at home or in birth centers across all racialized groups, with Black women leading, that number still is less than 2%. So let's not leave the 98 behind. While we know that 84% of pregnancy-related deaths are preventable, while we know that 88% of these births in the US are attended by physicians, and we know that more than 50% of these deaths are occurring between postpartum days 1 and 365, what is happening after people experience childbirth in a hospital setting, usually at the hands of physicians, and are dying? So if we were to reconceptualize, right, the experience of birthing in a hospital setting in the United States within the context of a Black woman defined definition of health equity, Dr. Kamara Phyllis Jones, maybe we would again rethink our approaches, our interpretations, right, and how we disseminate these data to the public and to professionals. So one health equity definition: providing opportunities, options, resources to achieve the highest level of health for all people based on individual and community level needs, independent of their social, economic, demographic, or geographic circumstances. And so I particularly love this definition by Dr. Jones from 2014. Health equity is the assurance of optimal conditions for all people, a perpetual process whereby systems and structures are required to value everyone equally, rectify historic inequities, and distribute resources according to need. Now let's sit with those definitions, right, of health equity. And then let's go back to birthing in a hospital in the United States, where we have assigned higher value of quality and safety based upon these measures, right to the left, which are all clinical outcome measures: full-term pregnancy, absence of medical conditions, comorbidities, optimal prenatal care utilization, a vaginal birth, perhaps with a small repair that did not extend into the rectum, having a normal weight infant, having a healthy infant, excuse me, a healthy infant with no need for being admitted to the NICU, having an infant that latched well to the breast, chest, body. These will all be considered high performing, high quality, and safe birthing experience, or this hospital would get designated as a high performing, high quality, and safe hospital. But that's because we are defining being safe as the absence of physical harm or minimizing the risk of patient harm. So in this setup, in this paradigm, a positive outcome equals the highest level of health as defined by the health system, which is what being safe means. So what if we have the same list of positive birth outcomes occur in the context of a Black mother, birthing person, who, when asked about her birth from 2019, and I interviewed 36 Black mothers and birthing people in Los Angeles and Oakland about their hospital births 2 years prior. So this birth occurred sometime between 2017 and 2019. And her response, when having all of these positive outcomes, this is what she said about her experience: we're human, treat the human. We know you're going to sew me back up, but I feel like a rag doll. Just because you stitched me back up don't mean I'm whole again. So what is it about this particular birth experience where this Black mother doesn't even feel like a human? She feels not even subhuman. She feels like an inanimate object, like a rag doll. What do we do with dolls? They get thrown around, we play with them, we dress them, they get torn up, they get given to pets. Is that how we want anyone, particularly Black mothers and birthing people, to experience when they are giving birth, period, in any place, but particularly in a hospital? So if we layer on this positive outcome with this dehumanizing experience, and we look at this within the context of health equity, the definitions that I shared with you for transparency and for accountability, then how do these suboptimal conditions that this Black mother experienced, and she's not alone, how do these systems and structures that do not value this Black mother, right? How is that considered safe, even in the context of a positive outcome, right? We still have these reinforcement of historic inequities where a Black person is feeling subhuman or even inhuman. We also have a lack of resource distribution according to need, which allows for an erosion of health equity. And then we get a positive outcome where everyone is praising and singing and excited, plus a dehumanizing experience where we have now the simultaneous existence of being safe and feeling unsafe. So again, is that particular birth experience safe? So what is happening? So on your screen, you can see what I've kind of come up with, this way to help people understand that perhaps we are prioritizing positive outcomes a little bit too much, and they are allowing us to miss what's actually being done because there's no way to name it, measure, monitor, and mitigate that. So is that by design that we're overemphasizing positive outcomes and not the dehumanizing experience or a humanizing experience? So traditionally, the system's intention is being safe. We use outcome measures to evaluate hospital performance. The reality, the community impact, is that outcome measures evaluate the performance of the reproducing body in birth. That body is what you're actually measuring, their performance in the hospital setting. Do those outcomes really draw you to what's happening in the interactions, in the decision making, in the communication, in the facilitating informed consent or informed refusal without retaliation? So here's a possibility that's both innovative and disruptive. Let's have experience measures that evaluate hospital treatment or mistreatment of mothers, birthing people, and their given and chosen kin as defined for, by, and with them. So going back to that birth, very simply, was that birth safe or unsafe? When she says, in the context of positive birth outcomes, we're human, treat the human. We know you're going to sew me back up, but I feel like a rag doll. Just because you stitched me back up don't mean I'm whole again. Is that a safe or unsafe birth? So in 2024, US News published this article. You know, we can say this could have been coercive, manipulative, but US News recognizes US hospitals with excellent patient outcomes. 26 maternity hospitals achieve excellent outcomes based on maternal outcomes, infant outcomes, and just alone based upon what I've shared in this little mini talk so far, and it's 34 minutes after the hour. So your newly acquired knowledge and understanding of being safe versus feeling safe, can hospitals with excellent Black patient outcomes truly be designated as safe for Black mothers and birthing people based alone on patient outcomes? Is that metric authentic, optimal, truthful, precise, accurate? So in an article published by Audrey Linden, Doctors Audrey Linden, Donnie Davis, Ajana Sharma, and myself, we call this into question, right? Emotional safety is patient safety. Let's move beyond defining safety as the absence of physical harm. What if we were to actually include psychological safety? And one of the reasons why we haven't been able to do that is because systems and structures, right, are getting to determine what safety not only means, but how it gets measured and monitored and mitigated, and even how these data get disseminated to groups. So when we exclude, erase, diminish, deny, patient experiences and community wisdom, right? In the epistemology of quality and safety, these four things can happen and they all lead to harm. So to the left of the side, we see this diminishing value of patient experiences as a safety indicator. We prioritize the outcome, which is why some folks can say, well, at least you survived. And you'll hear in my next talk how even the prioritization of survival allows the system to perpetuate obstetric violence and obstetric racism, and we have the data to support that. So again, diminishing the value of patient experiences as a safety indicator. Two, dismissing patient feelings and testimonies as real and reliable truths, just in the setup of a note, right? The SOAP note. S is for subjective, O is for objective. We are already training our clinicians and then allowing the existing workforce to then discipline or evaluate the future workforce on this way of structuring notes, but also how our relationship with what patients are telling us. We've already said that whatever a patient says is subjective, and what I do as a clinician is the truth. Third, we displace accountability from the system to the patient. And fourth, we deny the possibility of transforming patient safety meanings and measures. So the issue, very frankly, as we have seen with the horrific loss of most recently of a midwife, a doctor, nurse practitioner, and midwife, Dr. Smith, like we know if you, and she's not the only doctorally prepared, trained, and practicing scholar. We can go back to Dr. Shalom Irving. We can also go back to Dr. I think Shanice Wallace, a pediatric chief resident. We have Black women who are doctorally prepared and trained with multiple degrees who are demonstrating to us that if they are not protected in childbirth, then who else can be? So hospitals in the US do not routinely keep Black women, girls, and gender expansive people and their loved ones safe during pregnancy, labor, birth, and postpartum. So questions to be asking, how do Black mothers and birthing people feel in your care? What happens when standards of safety violate evidence-based standards of health equity? And there's a quote that I shared back in 2022. Just because you don't see the pathology that you define, again, just because you don't see the pathology that you define doesn't mean someone's not being hurt or harmed, says Dr. Scott, who created this instrument, right? It's very important that we recognize that we have misalignment, right, between the hospital's intentions of providing safe, high quality care and the patient's actual experiences. But we've known that misalignment has existed for some time. So bear with me, because I want to read directly from two of my publications, and then we'll move on to some practice. And then I'm definitely going to leave room for at least 10 minutes of questions. But hear me out. I would like to read directly from my two prior publications, The Rise of Black Feminist Intellectual Thought and Political Activism and Perinatal Quality Improvement, A Righteous Rage About Racism, Resistance, and Rigor, as well, that was published in Feminist Anthropology in 2021, as well as going back to that Emotional Safety is Patient Safety, which was published in 2023 in BMJ Quality and Safety. So here we go. Where and how do Black women safely enter and navigate a perinatal quality improvement matrix that fails to eliminate a 3 to 4-fold national death gap between pregnant and birthing Black people and pregnant and birthing people of other racialized groups? The problem with perinatal quality improvement and implementation research is not only limited to value proposition, patient perspectives, and the spread of ideas. In 2021, the most egregious problem with perinatal QI, or quality improvement, is the lack of collective righteous rage about the pervasive racialized and gendered misconceptions about Blackness and Black womanhood, particularly within the context of pregnancy and perinatal outcomes, conditions, and experiences. These are all disseminated throughout medicine, nursing, public health, healthcare, and QI in the form of problematic scripts, stories, and stereotypes. Such righteous rage is magnified for the lack of accountability for controlling, constraining, and censoring Black women's voices and intellectual thought. The problem with perinatal quality improvement, innovation, and transformation is the hypervisibility of Black women as victims and the structural exclusion and erasure of Black women as patient, community, content experts, which is why I will never start with the death sentence that we are more likely to die, because we are not victims. Any legal or ethical oversight, the fathers of perinatal quality improvement birthed the practice of epistemic redlining, the hidden ranking system that assigns value and visibility to the humanities, scholarship, voices, and lived experiences of white people or people adjacent to and protective of whiteness. Epistemic redlining epistemic redlining in perinatal quality improvement creates two forms of epistemic injustice that undermine Black women's and people's capacity as knowledge generators. So again, the structural and systemic exclusion of patient experiences and community wisdom and establishing the norms and narratives of emotional and cultural safety discounts the credibility of patient expressions and experiences of safety, as well as their expectations in the definition and evaluation of patient safety. Again, this results in two types of epistemic injustice, which occurs when people or groups are wronged in their capacity as knowers. So testimonial injustice occurs when prejudice combined with power differential undermines patients' perceived credibility. And then hermeneutical injustice occurs when patients and their communities of origin are not afforded full participation in generating shared meaning and measurement selection in the safety and quality arena, rendering them incapable of making sense of their own experiences and of having those experiences understood by others. Currently, epistemic injustice is deeply embodied and embedded in the patient safety field's normative foci. So hence my scholarship activism since 2018 is grounded in interrogating and disrupting the existing obstetric quality and patient safety paradigm by redistributing power of knowledge generation, protection, incubation, acceleration, and dissemination from the folks on the left, quality improvement experts, clinicians, data scientists, hospital administration, to the folks on the right in this particular work that mine focuses on, which can be a model to other groups. And in my work, it's Black mothers and birthing people, Black community leaders, Black women activists, Black women artists, Black women scholars, and allied scholars with shared expertise and experience in public health. So we'll go into a birth narrative. I will show you how to analyze it. I'll leave room for you to do it at least once, and then we'll have questions. And we are going to hopefully end on time. So in this birth narrative, the context, this couple, so this is a Black woman lawyer married to a Black man who's an engineer. Their household income is over $500,000. They live in the suburbs, 3 children in private school. This is not made up. This is actually a participant from the 2020 Sacred Birth Study. So go back again. Black woman lawyer married to a Black man engineer, household income over $500,000. They live in the suburbs, 3 children in private school, no medical comorbidities, full-term pregnancy. She has a doula, she has a lactation consultant, all these adequate birth outcomes, overutilized care, vaginal birth, no lacerations, all these things. They even had a whole community of people, a cocoon of support and safety, maternal and paternal grandparents, aunties, uncles, all these people were present at her birth. And this is what she experienced. In the PowerPoint, you would have heard the voice, but since I'm using Mentimeter, I'll read it for you. The biggest issue I had with my labor and delivery experience is the fact that I developed a birthing plan in writing prior to delivery that was in my chart regarding pain control, yet it was not honored. I expressed my need and want for an epidural to anyone who would listen, that cared for me during my time at the hospital, yet somehow I was forced to deliver naturally without any pain medication. This was not because I had a quick labor either. I got to the hospital at 7 p.m. They started my induction at about 10 p.m. I did not deliver until 6:06 a.m. So they had ample amount of time to fulfill my need for an epidural. There was a point where my husband was asleep and I could not yell loud enough to wake him due to the amount of pain I was in, but I could reach the nurse's button. I'll rephrase that again. I will repeat this correctly, but I could reach the nurse's button, but nobody would respond. I felt like I was in pure hell, and it was the worst, most painful, most traumatic experience I have had to endure when it comes to labor and delivery, and this is my 4th child. So in that birth, right, let's shift to what is emotional psychological safety. And some of you all shared this, right, in our prior activities. When we feel secure, connected, comfortable, supported, accepted, heard, understood, respected, valued, protected, then we feel emotionally safe. When we feel emotionally safe, we feel comfortable to be and show our most authentic and vulnerable self, and not in a pathologizing way, in a say of being free to be and anticipate being protected and having your needs fulfilled. Emotional safety is necessary for connection, communication, and collaboration. Again, things some of you described on the prior slides. When we experience emotional harm, the opposite of emotional safety, we become silent, distant, social withdrawn, disengaged, disconnected, and defensive due to violations of emotional safety. So going back to this narrative, I'm going to take those, I'll do one sentence, I'll do 2 sentences, and then give you the opportunity to actually analyze, and then we'll break for questions. So in the first sentence, right, that we see here on the right, the biggest issue I had with my labor and delivery experience is the fact that I developed a birthing plan in writing prior to delivery that was in my chart regarding pain control, yet it was not honored. So if I were to apply this kind of PHI approach, where we look at the patient action, the hospital response, and the impact, then I would interpret this one sentence in this way. What's the patient action? Their expression, experience, or expectation. Developed a birth plan, the expectation for pain control. That doesn't seem complicated. What was the hospital response? Well, she tells you the birth plan was not honored because she needed pain control. So we have a violation of the birth plan. What's the impact? We have a mismatch between patient expectation and patient experience. The birth plan and pain control feel big, like big patient priorities, but clearly not to the hospital, at least in the way this patient experiences, the hospital. We have a dismissal of the birth plan, which is really a violation of patient autonomy. And therefore, we have a violation of the patient's feelings of security, connection, comfort, support, acceptance, dignity, and protection. But where can we capture this if we are defining safety as only being safe and not feeling safe? Let's go to the second sentence and then we'll allow you to practice. Second sentence, I expressed my need and want for an epidural to anyone who would listen, that cared for me during my time at the hospital, yet somehow I was forced to deliver naturally without any pain medication. The PHI approach, patient action, which is an expression, an experience, or an expectation. The patient communicated the need and desire for the epidural. The patient expectation was to be seen, heard, valued, cared for, held, protected, and offered pain control with an epidural. Very clear. It's written out. It's also verbalized by both of them, the mother and the father. What is the hospital's response? Forced, unmedicated, and painful vaginal birth. What is the impact? Again, there's a mismatch between patient expectation, patient experience. Getting an epidural was a number one patient priority. And I understand being an OBGYN, how that cannot be the priority of a hospital. But how are we communicating, right, when we are falling short of what a priority is? We have a dismissal of pain severity, which is a violation of human rights for pain control. We also have a violation of the patient's feelings of security, connection, comfort, all of those things. I also analyzed this third sentence, which I'm going to bring back at the second talk, but I would like to give you the opportunity to do this. We're going to do it quickly, and then we'll have Q&A. So your goal still is to this PHI approach. We're going to take the next sentence, the fourth sentence, and you are going to tell me through your words and all of us anonymously, what's the patient action, their feeling or thought, what's the hospital response, and what's the impact. You can use short, clear, or concise phrases of 3 to 5 words. You don't need a dissertation. These sentences can be incomplete, which are encouraged and accepted. And this will be your interpretation of the narrative. And then I'll show you what my interpretation is, and then we will have a little bit of Q&A. So here's that fourth sentence. So here's the sentence on the left. I'm inviting you to write out what is the patient action? What is their expectation, experience, expression? This was not because I had a quick labor either. I got to the hospital at 7 p.m. I got to the hospital at 7 p.m. They started my induction at about 10 p.m. I did not deliver until 6:06 a.m. So they had ample time to fulfill my need for an epidural. So let's try this as a group. What is the patient expectation, experience, expression, or action in this one sentence? And it's not a trick question. Who will be brave enough or curious enough or creative enough to be a thank you, first responder, planned epidural, use of an epidural, get pain control, right? Thank you, expect epidural. That's very clear in this one sentence, to fulfill my need for an epidural, right? Again, thank you, responders. There will be time for the proper care and responding to my request. Exactly. This person, and this, just so you know, this is an open-ended response at the end of my survey before it was validated that had 81 plus items. And at the end, I simply said, thank you for completing the survey. Is there something else you want us to know? And over 400 Black mother birthing people out of 815 wrote entire paragraphs about their experiences. So by the patient giving you a timeline, right, the temporality, they are telling you there will be time enough for proper care and responding to my request. Thank you, responders. Let's go to the H, the same one sentence. Describe the hospital response to the patient. This is not a trick question. What is the hospital response as we are applying this PHI approach to this birth narrative. Ignorance of needs. Thank you, responders. Lack of response. Ignored the patient. Thank you, thank you, thank you. You can continue to add on. I'm just going to keep going. So I at least give you like 7 minutes to ask a question. Constantly ignoring her and her husband's petitions and rights. Thank you. Ignored the written birth plan, right? That's exactly what the hospital response was. Independent of how everybody on the team woke up on that day, this is the hospital's response to this particular patient, right? Now, let's end with this. What is the impact of the hospital's response on the patient from this one sentence, the fourth sentence of that narrative? What's the impact? Again, not a trick question. Thank you, first responders. Trauma, pain, grave loss of trust, trauma. Birth was harmful. Distrust of medical systems, traumatic delivery. Thank you, thank you, thank you all. Now you can see what I wrote from this one sentence. The patient action, unnecessary preventable worry. This is what I got from that. They experience unnecessary preventable worry, pain, and endurance of suffering. The hospital's response, a forced, unmedicated, painful vaginal birth, and the impact, a mismatch between patient expectation and patient experience, prolonged physical and emotional suffering. And we won't do it again, but we'll save this for next time. I have one more sentence for you all to practice with, but hopefully you get the gist of what this PHI approach is. Some of my truths that guide the work that I do. We believe, trust, value, and adore Black women, girls, and gender expansive people. Black women, girls, and gender expansive people are worthy. We protect, prioritize, cite, and amplify the voices, intellectual thoughts, lived experiences, and political activism of Black women, girls, and gender expansive people. We affirm, activate, advance, amplify the power and potential and not pathology of Black women, girls, and gender expansive people and our chosen and given kin. And this is a vision for what we have for sacred birth. I will share that for the next one because that is one of your Black women defined theories. But thank you for getting through this, just so you get a sense of emotional safety and emotional harm and how just violating how patients feel around safety, right, is a violation of autonomy, security, safety, trust, connection, community. I will see you all again next month. I know there's like 5 minutes left, but I want to make sure that you got just at least this part of the work. I will make sure you have information about my book, which is available. We also have a 20% discount. But thank you, thank you, thank you for getting through the first part of our talk, which is really the foundation for understanding the work that I do. Thank you. And so, this is can be a 4-part series, 2 hours each, but I wanted to give you just a kind of a preview of what I can do in terms of really training folks and just thinking how just in the simplicity of being safe versus feeling safe and how it's causing such trauma to patients, as well as we're learning moral distress and injury to the healthcare workers. So thank you for being with us today. I'm still here, Jill, if someone has questions.